So shared decision-making requires physicians or clinicians and patients to work together, to share information about the available options, and then to deliberate, weighing the pros and cons of those options to arrive at a decision by consensus. This requires the parties, the clinician and the patient, to work together as peers. In some cultures, there is the opportunity to do that because of the level of education, perhaps, of both the clinician and the patient, some cultural norms, and some expectations about patient-centeredness. In others, those expectations and that parity of education does not exist, and clinicians insist on creating relationships in which they are perceived as being superior to their patients, and patients feel the need to participate at that level of inferiority in order to get the grace, in order to get the goods of interacting with the healthcare system. So that's the impression. Now, does it play out in practice? We had a team in the University Cayetano Heredia in Lima go and look in the private and public sector in the healthcare in Peru to see to what extent are patients and clinicians participating in shared decision making. And of course, the answer was quite dismal. About 14% of the maximum level of engagement was achieved in that environment. Now, what's striking is that as a proportion is not particularly less than what we see in usual primary care in the United States. But I think the flavor of it was more clear. While in the United States we see little involvement of patients and little patient participation, it does not appear as dramatic as appears on the videos in the Peruvian situation, but the score is similar. The difference between doctors and patients in different cultures is quite striking, and it affects the opportunity to do shared decision making. In some countries, the consultation starts with the patient kissing the doctor's feet. In others, equally in the Southern Hemisphere, with perhaps more education and less difference between doctors and patients, there's still quite a bit of placing the doctor in a pedestal or in a godlike position. And as a result, questioning the doctor or challenging the doctor's recommendations will be ill-advised. In those cultures, patients learn to go from one doctor to the other until they get the advice they need, rather than challenge the doctor they first saw to try to see what's going on. So in those environments, shared decision-making is quite a bit away, given that we need to overcome that distance between the doctor and the patient until they can be on the same footing. What I'm looking forward the most about the conference this year, of course, is to see where the community is at as it approaches its second decade of existence, what progress is made, and where the researchers are seeing the edge of development in shared decision making. But I'm also very excited to see what interaction will occur between this community, mature and forward-looking, with the culture of Peru and the culture of healthcare in Peru and in the rest of emerging economies, where those economies, now that they have some resource and opportunities, have to decide in which direction they ought to go. And my hope and dream will be that this community of very progressive, forward-looking people that are trying to put the patient in the middle, put the patient in the center, will influence the direction which healthcare's delivery systems in developing countries like my own in Peru will take in the future.